Today, we're diving deep into one of the most critical, densely packed bits of neural real estate in the entire brain, the pons. You can think of it like a massive highway interchange where countless signals for movement, sensation, and consciousness are all crossing paths. And a tiny, tiny lesion here can have some absolutely devastating and, frankly, pretty bizarre consequences. So let's get into it and build ourselves a map to decode its secrets. So first up, let's just get our bearings. The pons, you can see it right here, sits smack in the middle of the brainstem. It's the bridge, connecting the midbrain above to the medulla below. And its location, that's exactly why understanding its internal geography is so incredibly important for making a diagnosis.
And to really kick things off, let me throw a clinical mystery at you, one that has everything to do with the pons. Imagine a patient who is completely frozen. They seem unresponsive, but their mind is 100% active and aware, and they can only communicate using their eyes. This is locked-in syndrome, and I promise, by the end of this explainer, you'll understand exactly how it happens.
Okay, so to crack that mystery, we first need to understand the basic layout of the place. We've got to map out the main highways and the side streets before we can really get a handle on the traffic jams that a lesion can cause.
The thing that just jumps out at you when you look at the pons is how dominant that front part is, the part we call the basis pontis. See, unlike the midbrain, the pons doesn't have a roof, a tectum. Instead, its whole function is dominated by this absolutely massive motor highway, carrying all the signals down from the cortex that control our body, our face, and that coordinate with the cerebellum. This really is command central for all motor output.
So with all these different tracks running through such a tight space, how on earth do we keep them all straight? Well, luckily for us, there's a brilliantly simple organizing principle that's going to act as our diagnostic compass.
Okay, this slide right here, this is the key to everything. It all boils down to a simple medial versus lateral divide. Right down the midline, we've got the 4 M's: the motor pathway, the medial lemniscus for sensation, the medial longitudinal fasciculus for eye movements, and the motor nucleus of cranial nerve 6. Then, out on the sides, we have the 4 S's: spinothalamic, spinocerebellar, spinal nucleus of V, and the sympathetic pathway. This is our foundation: medial M's, lateral S's. Seriously, commit this one to memory.
So let's put our map to the test. We'll start our tour up front in the ventral or anterior region, the territory of that massive motor highway we were just talking about.
So, if a lesion, like this one shown in red, streaks right at the heart of the basis pontis, well, it should come as no surprise that syndromes in this area are defined by one thing above all else: motor catastrophe. Our first case study is Millard-Glubler syndrome. In this one, a very specific, localized lesion catches the fibers of cranial nerves 6 and 7, just as they're heading out. And the result? On the same side as the lesion, ipsilaterally, the patient can't look sideways and has facial paralysis. It's a clean, localized hit. Okay, so what happens if that lesion scoots over just a little bit and catches that main motor pathway? Well, then we get Raman syndrome. You still have the inability to look sideways on the same side, that's from the CN6 hit, but now you add severe weakness on the opposite side of the body, contralateral hemiplegia. See how just a tiny shift in location creates a completely different clinical picture?
And here we are back to our opening mystery. Locked-in syndrome is the ultimate ventral lesion. It's a bilateral, total destruction of the basis pontis, knocking out all the corticospinal and cortical bulbar tracts. This effectively severs the brain's connection to the limbs and almost all the cranial nerves. But, and this is the incredible part, the wiring for vertical eye movements, that comes from cranial nerves 3 and 4, which are located higher up in the midbrain. That pathway gets spared. It's like a secret override that stays intact, allowing for that all-important vertical gaze and blinking.
Okay, let's move our tour from that ventral motor highway and head around back to the posterior or dorsal region. This area is all about intricate coordination, especially when it comes to our eyes. So unlike the big, straightforward motor highways up front, the dorsal pons is packed with cranial nerve nuclei and all the complex circuits that make them work together. Lesions back here tend to disrupt the very delicate dance of eye movements. Facial collicular syndrome is a perfect example of why the local anatomy is so crucial. The key here, as you can see, is that the facial nerve tract, CN7, literally does a loop-de-loop around the nucleus of CN6. So a lesion right there is going to disrupt both of them, and it's also going to hit the adjacent MLF, that M tract that's so important for coordinating the two eyes. And what you get is a really complex gaze palsy.
Now, this is a great reminder that lesions of the brain don't always respect our neat little boundaries. Foveal syndrome is a perfect example. It starts in the back, dorsally, taking out the lateral gaze center and the facial nerve. But then, the lesion extends forward, ventrally, and hits the motor pathway. So the patient shows up with an inability to look sideways, facial paralysis, and weakness on the opposite side of their body. It's a dorsal syndrome that bleeds right into the ventral territory.
All right, for our final stop on the tour, let's move out to the sides of the pons. And if you remember our diagnostic compass, you know exactly what that means. We are now in the land of the 4 S's.
That's right, lateral lesions are all about disrupting sensory and autonomic information. They create this complex scramble of deficits by hitting the spinal thalamic tract for pain and temperature, the spinocerebellar tract for coordination, the spinal nucleus of V for facial sensation, and the sympathetic pathway. The textbook example of this is AICA syndrome, named right after the artery that supplies this area, and it takes out that classic quartet of S tracts. The crucial takeaway is this: you get contralateral body pain and temperature loss, but you get ipsilateral, same-sided, facial sensation loss and ataxia. Now, why ipsilateral ataxia? It's because this lesion is in the lower pons after those spinocerebellar fibers have already crossed over.
And just like we saw with foveal, lateral lesions can also extend inward. In Marie-Foy syndrome, you take that classic lateral presentation, all the sensory and ataxic problems, and you just add contralateral weakness, or hemiparesis, because the lesion has grown medially to hit the motor tract. The easiest way to think of it is AICA plus weakness.
Okay, we've toured the entire pons, ventral, dorsal, and lateral. So now let's zoom out and put it all together into some really powerful practical rules you can actually use.
Here's a fantastic clinical shortcut, a real pro tip. The vast majority of these classic Pontine syndromes involve that corticospinal tract, which means they cause motor weakness. So if your patient does not have motor weakness, your diagnostic focus should immediately shift to a pure lateral lesion, like Icica syndrome. It's a really powerful rule of exclusion. And finally, here it is, the complete map. This diagnostic matrix pulls everything we've talked about together in one place. You can see the syndrome, its location, the specific tracks it hits, and the clinical signs that result. This isn't just a list of facts to memorize. It's a pattern recognition tool that's built on the spatial logic of the pons itself.
So the crucial point here is that we've transformed what seems like a complex jumble of names into a logical, location-based map. The next time you're faced with these symptoms, don't just try to memorize syndromes. Instead, ask yourself, is it medial or lateral? Is it ventral or dorsal? Because by thinking spatially, you can navigate the neural crossroads of the pons and actually pinpoint the problem.